spending being taken into account in our region. We are offering testing to all these patients.
Thanks. Professor Hanegabra.
So the reason the guideline is like this in SGO is because 50% of those who are BRCA mutant at presentation have no family history.
Absolutely, yes. Thank you very much for that. Very, very important. So BRCA1 and 2 mutation carriers, about, I thought it's 40, but Professor Hanegabra is saying 50, could have no family history. She could be the first one to have the hit of the gene and present with the cancer. Okay. Risk-reducing bilateral salpingooophorectomy rather than screening is the mainstay of managing women with constitutional, i.e. germline BRCA1 and 2 mutations. Okay, so there's very good consensus that really you should consider that surgery. For women who are very anxious to be left without any form of screening, we used to do scans on them in Manchester, but call it active monitoring. So we are not labeling her as a screening, but just active monitoring of her condition until we do the risk-reducing salpingooophorectomy. Thank you.
May I just make a comment? I think
Please.
that it should be differentiated between BRCA1 and BRCA2. Of course, the occurrence of BRCA2 is later.
Yes.
And so the patients, particularly if they are just healthy BRCA carriers, should be informed about the different options in terms of timing.
Yes, thank you very much. Women undergoing risk-reducing bilateral salpingooophorectomy premenopausally, i.e. in their early 40s, should be offered hormone replacement therapy until the natural age of the menopause. Good agreement there, more than 80%. And that's true. The guidelines is saying if they have a personal history of breast cancer, then you may counsel her otherwise to use other modalities. Okay, thank you. Screening for ovarian cancer using the CA125 or transvaginal ultrasound scan may be offered to postmenopausal women in order to early detect the disease and reduce mortality. Okay.
But, sorry, Ahmed, I just need to comment. Do you mean to all postmenopausal women or the high-risk group?
High-risk group.
If it's like that, there is no evidence that screening will reduce morbidity and mortality so far.
Okay.
But if you say the high-risk group can be carried on till the postmenopause, would be okay.
Well, we just heard that the high-risk group screening is not good. The risk-reducing surgery is the standard treatment. So that's the general population. All postmenopausal women should have annual...
All trials have failed to show any evidence.
Thank you. Professor Ashraf Nasr.
Again, there is no evidence that to be for general population, but I think it's accepted practice for high-risk group, like this woman.
Who are the high-risk group?
Postmenopausal women, especially if they have any adnexal mass, even may not be seen clinically, but I think it could be accepted to have, if available, transvaginal scan and C125 every 6 months.
So, Professor Andreas Papadopoulos, the current evidence, Professor?
Yes, so the UKC tox study was published towards the end of last year, having screened over 200,000 women. They randomized them to three groups: observation only, ultrasound scan, and multimodal screening using ultrasound scan and CA125 measurements. When they looked at the results, there was no significant detection differences between the three groups, but when they sub-analyzed and took out the prevalent cases, the cases thought to have ovarian cancer at the time of the start of the study, they demonstrated 28% reduction in mortality. However, that equates to one case saved for every 641 women screened over a 14-year period. Obviously, a very expensive trial.
Very expensive. Thank you. So dose-dense combined carboplatin and paclitaxel chemotherapy regime offers better progression-free and overall survival, and should be standard of care in offering adjuvant treatment to women with advanced ovarian cancer. So a comment from perhaps Professor Hani or Professor Gamal, Professor
I think
Fedro.
the data showed that this dose-dense carboplatin means carboplatin day 1 and paclitaxel day 1, 8, and 15 every 3 weeks showed a significant difference overall survival and the progression-free survival. However, the regimen may be toxic for elderly patients, so maybe will be suitable for young patients.
Professor Hani Gabra.
Yeah, there are obviously giving Taxol broken up to elderly people is not a bad idea. However, the data around progression-free and overall survival show the biggest ever survival advantage in any clinical trial in ovarian cancer ever in the Japanese study, which introduced carboplatin and weekly Taxol versus 3-weekly treatment, and that was for both progression-free and overall survival. However, when this trial was repeated in the States, it was negative, and in Italy, it was negative. However, the trial in the States, because of local issues around the use of Avastin, demonstrated that in an unplanned subgroup analysis, those people who somehow didn't get Avastin in the clinical trial did show benefit from the weekly Taxol. So we have 2 clinical trials, or 1.5 clinical trials, that show some benefit from progression-free and overall survival, and 1 Italian study that shows no difference. We hope that this will be resolved from a clinical trial currently led from Manchester in the UK called ICON 8, which will definitively answer this question.
Thank you. Professor Sugar-Baker, you want to?
The standard of care at my institution is not dose-dense carboplatin and paclitaxel, but a combination of intraperitoneal and systemic chemotherapy over 6 months, the Armstrong regimen.
And that intraperitoneal is not heated, it's just intraperitoneal.
That is correct. It's a normothermic chemotherapy that's interspersed with the systemic chemotherapy in a somewhat complicated fashion, but it does work.
And the discontinuation rate of treatment?
We're getting better and better. We put in the ports at the time of the cytoreduction, and that seems to work better, even if there's been an intestinal anastomosis. And I think the latest data for us is about 80% of patients make it to 5. The number 6 seems to be a problem. It falls off. But 80% of patients made it to 5 rounds of the Armstrong regimen.
Excellent, thank you. Professor Hani Gabra wanted to give a last comment.
I mean, regretfully, the issue of intraperitoneal chemotherapy makes most medical oncologists put ice in a bucket and put it on their heads because it's so painful, because these studies are unbalanced. They're not just about intraperitoneal therapy, they are also about differences in dose density and chemotherapy. However, the Japanese again are coming to our rescue by doing the proper trials which show equi-dose density of intravenous and intraperitoneal chemotherapy. However, of course, it won't be resolved, because when we get a clean result from the Japanese studies, we'll then have to repeat them across the rest of the world because of the genetic differences. So I agree with Professor Sugarbaker. There's got to be a role for intraperitoneal chemotherapy, but the acquisition of the correct randomized data is going to be painful.
Thank you. Professor Magid Abu Saada.
I want to ask Professor Sugarbaker, during the primary surgery, you put a catheter to be used for introduction of the intraperitoneal non-heated chemotherapy later on, during the operation.
Yes.
Okay.
Thank you.
The only exception to that is if you think you've had contamination with, say, a low colorectal anastomosis, something like that. If you think you've had contamination, then no. But even with an intestinal anastomosis, we wash very carefully afterwards. We prep the skin again, and the insertion of the port is like a whole nother procedure. And I think that with the proper port selection and a proper insertion, it's a very safe thing to do, and painful installations don't seem to be an issue anymore.
Yes, it is a part of the primary procedure.
Correct.
Yes, okay. Because we are doing such things in some patients, but not all patients.
Okay, thank you. Adjuvant treatment approach to epithelial ovarian cancer should keep in mind the intrinsic histological, biological differences, such as that of type 2 and type 1 and type 2 subgroups of epithelial ovarian cancer. That's very good. So yes, this is true, and the distinction is going to be more and more obvious in terms of the biomarkers to select the treatment of choice as well. Any comments?
I just
Professor
want to say that Professor Gabra had done chemotherapeutic sensitivities, so that I would ask him to comment on that one.
Professor Hani Gabra.
Ovarian cancer is many diseases. If you break it down into its molecules, they are completely different disorders. So the notion that we should use the same treatment for completely different diseases is ridiculous. So we have to think about these individual diseases and to try and to target the treatment properly. The problem with that is that there is a dominant group called serous high-grade carcinoma, which is amenable to proper investigation. All the other histological subtypes are rare cancers, so you have to organize multinational studies in order to get anywhere with these. So type 1 disease with low-grade serous carcinoma, for instance, is for the first time going to be subjected to a randomized clinical trial. It's taken about 4 years to set this trial up, and I just got an email today saying that our center is finally open for it, and I guess that's the same around the world. So it's difficult to do these trials, but we have to do that in order to make progress.
Thank you very much. We'll move on to question 16. In advanced ovarian cancer, if complete optimal site reduction is thought unachievable via only ultra-radical surgery, multi-visceral resection, that's what we mean, it is still preferable to neoadjuvant chemotherapy, i.e. you go for the multi-visceral resection rather than giving neoadjuvant chemotherapy. This is in the preoperative assessment setting. Okay. Any comments? Professor Said?
Yeah, although there is no evidence that primary surgery does better than neoadjuvant chemotherapy, but now the consensus is that if you're not able to do primary cytoreductive surgery, go for neoadjuvant. This is another contentious area, but the resistance to do neoadjuvant is getting down and down than before, although there is no strong evidence that it makes any difference.
Any counter comments, Professor Devine?
No, it's not counter comment. It's just to sort of say EORTC and Chorus confirm that that outcome is similar, but it's safer. It has a less morbidity, and that's the key here.
Thank you. Any more comments?